On Health Her Way, we're asking the questions you want answered about your body.
Together with our female healthcare experts, we're diving into the questions that might seem too scary, too silly, trivial, or taboo. No topic is off limits.
Join us as we talk about Health Her Way. Welcome to Health Her Way. I'm Brooklyn Albert.
And I'm Meredith Cunningham. And today we are joined by the lovely Dr. Jennifer Phy. Thank you for being here.
Thank you for having me.
Absolutely. So for those of you who don't know, our guest, Dr. Jennifer Phy, is a board-certified obstetric and gynecology and subspecialty board-certified in reproductive endocrinology and infertility. She has practiced in Lubbock for more than 20 years, and we are very lucky to have her here at Covenant Health and here today. So we're going to dive in to some topics that we need some clarification on, because we hear about them a lot from friends, from the media. I don't think we actually have a clear idea. So we're going to talk today about PCOS and endometriosis.
Okay.
Can you do that?
I can do it.
Perfect. Let's make it easy on everybody, and we'll take it one by one. So let's start with PCOS. What is that?
PCOS stands for Polycystic Ovary Syndrome. And this is a syndrome, meaning it has different features. Not every woman is going to present the same way or have the same issues. It was originally described in the 1930s by two male gynecologists. At that time, they didn't have a lot of sophisticated instruments and imaging, so the name polycystic ovaries came from the appearance of these ovaries at times of surgery. They sort of have a little bubble wrap appearance, kind of little what looks like cysts around the outside. And so it became named polycystic ovary syndrome. It can be a really tricky, frustrating condition that often takes a long time to get a diagnosis. Many studies have shown it might take years or seeing multiple different healthcare providers for women to finally realize they have PCOS. So this is a condition where the menstrual cycles tend to be irregular. That's one of the key criteria, and they tend to be a little farther apart. The second component of it would be some elevation of male-type hormones. So this could either be by a blood test, like maybe checking testosterone levels or another hormone called DHEAS, or it could simply be clinically by what the woman's experiencing, like painful cystic acne. She might have scalp hair thinning or a little darker, coarser body hair. Any of those, but either laboratory evaluation or clinical findings could meet that criteria. And finally, the other diagnostic criteria is the appearance of a polycystic ovary by ultrasound. And they have a very classic appearance where they're a little bit rounder, and the follicles, which are actually egg sacs, they are not cysts. They're actually little egg sacs that each carry an egg inside. They kind of line up around the outside of the ovary and are just kind of waiting for somebody to tell them what to do. So the name itself, polycystic ovary syndrome, is not so great. It's not really indicative of what the condition is, but that's the name we're stuck with for now. And so that's just a little overview of the common symptoms that patients experience with this condition.
So historically, is the chief complaint that maybe women originally have that leads them on this journey to a PCOS diagnosis is an irregular period, or is there anything else that's like you said the acne and things like that? But I guess to me, like, I wouldn't immediately think just because my period's irregular, I have PCOS. Is that why it's so hard to diagnose?
Yes, because a lot of women have irregular cycles for other reasons. And PCOS kind of sneaks up on us. It starts around adolescence. So that's that age group, they're not usually seeing a doctor very regularly. They're a little bit older to be seen by their pediatrician and a little young to be seen by a gynecologist. So they're kind of in this no man's land where they're just like, is this normal? Is this not normal? Adolescence is a common time where young girls tend to gain a little bit of weight, and acne is common. So it just kind of sneaks up. And so irregular periods plus cystic acne or this darker, coarser hair growth in the midline, like between the belly button and the pubic area, that's a little bit unusual. And so I would say those are the key features that I'd watch for. And really, if you're strictly going by the diagnostic criteria for PCOS, that's enough to call it PCOS. Now, you're supposed to rule out other things, do lab work and ultrasound, but when I get to teach medical students or resident physicians, I always encourage them, I would rather you over recognize it than miss it. It's very important to bring these symptoms up to someone's healthcare provider so that they can check it out further.
So is this a genetic condition?
It is believed to be linked to an insulin receptor abnormality. It seems to be autosomal dominant. That means something that's very prevalent and runs in families. And some studies have even shown that brothers of women with PCOS have a lot of the same metabolic conditions. So we actually don't know exactly what the cause is. I do believe that it's something we have all along that just declares itself in adolescence. So, like most medical conditions, it does run in families, but it's so common. They estimate 1 in 9 women has PCOS.
Wow.
So, it can certainly just randomly happen too.
So what are the treatments for PCOS? How can we help women? Is there a way to get it on a regular cycle? Is there a way to get that acne gone? Is there a way? Nobody wants a happy trail. Male shoot on boys. That's not what we want. So what can we do? How can we help those women who are diagnosed with this?
Yes, there are a lot of ways to help. And so I would ask that women who, suspect they have PCOS or know that they have PCOS, that they might see someone who has a special interest in PCOS and really does kind of try to find the most worrisome symptom for that patient. What are their long-term goals? What's bothering them the most? So, depending on if a woman is just wanting to regulate her menstruation but isn't ready to try to conceive, there are many medications that can regulate the cycles better. You can give progesterone, which is just a tablet usually. You can give that monthly for a week to 10 days to have more regular cycles. You can use birth control pills. A lot of women don't like when a healthcare provider just puts them on birth control pills and doesn't give an explanation, but birth control pills really help to regulate the periods. They help to bind testosterone, so that's going to really improve complexion and help to diminish the body hair growth. Many times, dermatologists will prescribe birth control pills, not for birth control, but for complexion symptoms. And then if women decide that they want to have a baby, which is one of my favorite areas of medicine, there's many different medications that can really help to improve ovulation. So there's medications called letrozole and clomiphene. These are true medications to help women ovulate better. Metformin is a very commonly prescribed medication for PCOS that has some ability to improve some of the symptoms as well. So we have a lot of tricks up our sleeve if patients will just voice, what are their goals, what symptoms are bothering them, and to really see someone who respects and is passionate about PCOS so they don't get the runaround.
So you kind of mentioned it a second ago, and I want to dive a little deeper into it, but how does PCOS affect fertility? Is it because there is no regular schedule? And so when you're think maybe I'm ovulating now, let's do this today. And you're like, oh no, you were way off because your body's not on a regular. Is that the biggest concern when it comes to that?
The biggest concern.
Okay.
So anovulation, meaning the not ovulating, or oligoovulation, meaning it's infrequent. I mean, in a perfect world, we're only fertile 24 hours a month. So, every month our body chooses the lucky egg of the month. That egg releases. It is only fertilizable and friendly to the sperm for 24 hours. And if we miss it, that chance is over. Now, in PCOS, women might not be ovulating at all. Like they might have no periods, which means they're not ovulating at all, or it might be so unpredictable. And I find this to be really frustrating for patients because they might be using an app on their phone or something that that's making assumptions. Like it's assuming that you're ovulating regularly, but you're not.
Mhm.
And so it is the number one cause of infertility related to ovulation. And so it is probably accounts for about half of the patients that we see in our practice are due to PCOS and just not ovulating on time.
Wow. You're very famous for something.
Well, I have done a lot of research on nutrition
Mhm.
and polycystic ovary syndrome. So in my training, I trained at Mayo Clinic, which was amazing. And we did a lot of research on PCOS and I loved it. So I really focused on that for 3 years on kind of the traditional medical treatments. And then returning to Lubbock, I had the opportunity to work with a dietitian and together, we really uh, did a lot of research to find a nutrition plan that makes an enormous difference for women with PCOS. And it is now kind of my new first line treatment for PCOS. And we were very fortunate to win a prize paper at our fertility conference on this. So it is really hot off the press, legitimate research based findings. And so women with PCOS tend to be sensitive to dairy products, especially like just regular milk or whey protein. They are sensitive to grains, where a lot of times when they're eating grains, they feel very bloaty and kind of like a brick in their stomach. And then starchy foods. So, starchy foods are like corn, potatoes, peas, and beans. All of these I love, by the way. But
Don't we all?
yes, but these foods, for some reason, and we're still working on figuring out why, but these foods, the dairy, grains, and starchy vegetables, they cause an enormous secretion of insulin. Now, we all need some insulin to survive, and insulin is a good thing, but excessive insulin causes problems.
Mhm.
So, excessive insulin is going to make more testosterone, it's going to make hair growth worse, and it supports fat storage. So when we have high doses of insulin in our system, our body kind of goes into this fat storage hibernation mode. So what we found in our research, when you don't eat those things and really just eat an unlimited amount of lean proteins, lean meats, fruits and veggies, nuts and seeds, there's lots of things you can eat without counting any fats or calories or carbs. The women popped up pregnant and their insulin and glucose improved. Their testosterone went down. They felt better. And of course, selfishly, I wanted them to get pregnant. So this was, so exciting. But in our study that we're working to publish now, with no medications or exercise or limitations of quantities of food, the women following this nutrition plan on average lost 19 pounds in 8 weeks.
Wow.
Well,
Like there's virtually nothing I could do to help someone lose that kind of weight without multiple medications and a lot of exercise. So it was such a pleasant surprise to find something that really works. So there are a lot of things people can do naturally and by nutrition, and we continue to learn, like, why is it that way? We don't know yet, but at least we found something easy that makes a dramatic difference.
So that might be especially helpful for people who don't want to be on a lot of medication or,
Right.
want to take maybe a more natural, holistic route first. And so that's awesome.
we talked about nutrition a little bit, but I'm interested to know also what physical activity or exercise has to do or help with managing PCOS.
Yes. Well, I think the nutrition takes priority, and I hear this from patients that, it seems like no matter how much exercise they're doing, it can often be a struggle to get their weight down and to achieve kind of the body changes that they're desiring. So we certainly encourage exercise. It is a great stress reliever. It improves your cardiovascular health. It improves your insulin sensitivity. And I think that patients benefit most from sustained, like low impact exercise that's aerobic exercise, like let's say 30 to 40 minutes most days of the week, like 4 to 5 days of the week. I feel like they are the happiest and notice the best response rather than ones that are doing extremes of exercise or lifting a lot of weights. Certainly, if people want to do that, they can, but it just doesn't seem to achieve the goal of weight loss in most cases. And I just don't want someone to feel like they just have to destroy themselves in the gym or exercising and get frustrated. We encourage it as an additional overall health benefit. So I think the low impact aerobic activities most days of the week would be what I'd recommend.
Okay, so what role does stress play in the management of PCOS, and what stress reduction techniques do you recommend?
I think stress plays a huge role in this. And in our new patient questionnaire, we ask, are you under a lot of stress? And almost every time that box is checked because just by nature of having PCOS and desiring pregnancy, it's really hard. So I don't think eliminating stress is possible. I mean, just our lives are crazy and pursuing pregnancy and becoming a parent, it is just inherent to have some stresses. So we encourage patients to, let us know their stress levels. How can we help to improve that? I think there is a huge stress reduction when women understand their medical condition. We make a plan. We might make a plan A, B, C, and D. And that I just see the stress kind of melt away. There are also, other things we can do like meditation and massage. We encourage shopping because, sometimes partners don't like that so much, but just the positivity and
It's the endorphins, right?
yes, the
It's
endorphins
my stress reliever.
yes, yes. And so I think that it's impossible to eliminate stress, but stress doesn't help anything. And I think that the patients that go into their treatment plan open-minded, not limiting and saying, I will never do this, or what will I do if this fails, to just go into it open-minded with some positivity and confidence and to do our best to reduce the stress, to help them eat well, drink lots of water, try to get good sleep, do some self-care. It makes an enormous difference. But just by nature, the patients I meet, they're usually not that happy to
Yeah.
have to come and seek help to conceive. But we try to make it as fun and happy and clear and including the patients as much as possible to reduce that stress.
And that leads into a great next question that we have, which is we've talked a lot about the physicality of PCOS and the impacts of trying to conceive, but how does it also impact your patients emotionally and mentally having to go through all of this? Like, obviously, it's very annoying to be surprised by Aunt Flo whenever she decides to show up, but also just, again, the emotional and mental toll of it all.
Yes, well, PCOS is definitely linked to higher incidence of anxiety and depression. They've done MRIs of the brain where the brain activity is different in PCOS, and you can really have this kind of distraction and focusing on food and cravings that are a bit overwhelming and consuming for people. So with PCOS, it's a real deal that anxiety and depression are heightened, and then fertility issues on top of it really can take a toll. So we just again like to see, can we manage this mental health, these feelings, by talking through it, making a good plan, stress reduction, or many times we collaborate with a therapist, psychologist. We might use medications to try to get through this difficult time. Doesn't have to be forever, but just for situational anxiety and depression, we use every tool, whatever it takes to help that patient feel more comfortable and confident moving forward.
So I saw that PCOS can also lead to type 2 diabetes, cardiovascular issues. So can you kind of talk about how important it is to get on top of it and manage it?
Yes. On the Centers for Disease Control website, which is a very very helpful, extremely accurate source for information. If you just type CDC and PCOS, a lot of national statistics will come up, and it says there half of women with PCOS will be diabetic by age 40.
Wow.
Wow.
So that's 1 in 9 women who has PCOS. Half are going to be diabetic before they're 40. And we diagnose it frequently in our patients seeking fertility, and they might be in their 20s or 30s. You're just not expecting this.
Mhm.
And so diabetes can affect every organ, your vision, your nerves, your kidneys, your blood pressure, everything. So it's so important, even if someone's not seeking pregnancy, to have someone that can recognize and treat the PCOS to be able to correct that metabolic imbalance. And so the high lipids and triglycerides, those are also common with PCOS. Those raise our risk of heart disease. And heart disease in women is one of the number one killers.
Mhm.
So very, very important to recognize that. And I think that's where focusing it so much in the gynecology world does a disservice to these women, because it really is head to toe. It's
Mhm.
really every organ, every system can be impacted by PCOS. And I think in our lifetimes, they're going to change the name. They're going to have it be, something that primary care providers will more easily recognize and feel more confident managing, because that's really what these women deserve. It's much more than just managing periods and having babies. So, I appreciate these questions, because in my patient population, they want a baby. They're
Mhm.
very focused on that, but we want to focus on long-term health. And PCOS is kind of a forever thing. We want to keep taking care of patients to reduce their risk of heart disease and diabetes, even after they've completed childbearing.
Is there anything else about PCOS that we haven't necessarily covered that you feel like is important for our audience to know?
Yes, I think that there's really a common misconception that weight, excess weight causes PCOS, and that is simply not true. I'm super annoyed when I hear it kind of portrayed that way. So PCOS causes a very unfair metabolism. I mean, really unfair, where patients can be eating right, exercising, doing all the right things, and their body chemistry, especially with this high insulin, is driving fat storage. And we proved this in a research paper where even fasting, like nothing to eat or drink but water, the women with PCOS, their bodies were still storing fat. That's really unfair. So higher weight does not cause PCOS. It can exacerbate, make the symptoms worse. But I would really like for women who are struggling with this to know this is not their fault. This is a true head to toe metabolic condition. It's not perfectly understood. It can be equally frustrating to healthcare providers because we just don't have a lot of great treatment options. So I would just encourage people to uh, connect with someone who is really going to be understanding about PCOS, and to not settle. Their quality of life. There's so many different things PCOS can affect, and I just want them to keep seeking and keep working towards having their goals achieved.
Well, this has been a great conversation. Y'all come back for our next episode, part 2, and we will talk to you about endometriosis. So stay tuned.
This podcast explores health-related topics with experts in their specialty for entertainment purposes only.
The information shared and discussed should not be considered as medical advice under any circumstance and is not intended to replace professional medical advice.
The views expressed do not reflect the views of Covenant Health System. For questions related to your personal health, always contact your physician.